Insulinoma is a rare type of tumor that arises from the insulin-producing beta cells of the pancreas. These tumors are typically small and can be benign or malignant, with the vast majority being benign. Insulinomas produce insulin independently, leading to inappropriate and unregulated secretion of insulin, which causes hypoglycemia, low blood sugar levels. Characteristics of insulinoma. Prevalence. Insulinomas are the most common type of functional pancreatic neuroendocrine tumor, but are still relatively rare, with an incidence of about 1 to 4 cases per million people per year. Symptoms. Caused by hypoglycemia and may include confusion, weakness, sweating, palpitations, hunger, visual disturbances, seizures, and loss of consciousness. Symptoms often occur during fasting or prolonged periods without food. Diagnosis. Whipple's triad is used to suggest the diagnosis, which includes symptoms of hypoglycemia, low plasma glucose at the time of symptoms, and relief of symptoms after glucose is given. Fasting glucose test. Patients are monitored during a supervised fast up to 72 hours until hypoglycemic symptoms develop, and blood tests are taken to measure insulin, glucose, and C-peptide levels. Imaging. Endoscopic ultrasound, computed tomography, CT, magnetic resonance imaging, MRI, and somatostatin receptor scintigraphy can be used to localize the tumor. Treatment. Surgical removal. The primary treatment for insulinoma is the surgical removal of the tumor. In the case of benign tumors, this is often curative. Medical management. In patients who are not surgical candidates, or to manage symptoms preoperatively, medications that reduce insulin secretion, such as diazoxide, or increase blood sugar, such as glucagon, may be used. Management of malignant insulinomas involves a combination of surgery, targeted therapies, chemotherapy, and management of hypoglycemia. Prognosis. The prognosis for patients with insulinoma is generally good, especially for those with benign tumors that have been completely removed. Malignant insulinomas may have a more challenging course due to the potential for metastasis. High yield points. Insulinomas are rare pancreatic tumors that overproduce insulin, leading to potentially dangerous hypoglycemia. The diagnosis is often suggested by Whipple's triad and confirmed by biochemical testing during a supervised fast, followed by tumor localization using imaging techniques. Treatment primarily involves surgical removal of the tumor, with a good prognosis in cases of complete resection of benign tumors. Patients with insulinoma need careful preoperative and postoperative management to control blood glucose levels. Clinical case, insulinoma. Patient information. Age, 45-year-old male. Occupation, high school teacher. Medical history, no significant past medical history. Non-smoker, moderate alcohol use. Presenting complaint. The patient presents to the clinic with recurrent episodes of confusion, tremors, and sweating, particularly in the mornings before breakfast or after long periods without eating. History of present illness. The patient reports that the symptoms have been occurring for the past 6 months, but have recently become more frequent and severe. He notes that eating or drinking something sweet alleviates his symptoms within minutes. He also mentions a recent episode of losing consciousness, after which he decided to seek medical attention. Physical examination. General, appears well-nourished and in no acute distress. Vital signs. Blood pressure 130/85 mm/Hg, heart rate 72 BPM, BMI 25 kilograms per meter squared. Neurological exam, normal with no focal deficits. Cardiovascular, respiratory, abdominal exams, unremarkable. Diagnostic workup, supervised 72-hour fast, initiated due to suspicion of an insulin-secreting tumor. The patient developed symptoms of hypoglycemia with a blood glucose level of 40 milligrams per deciliter, insulin level of 25 μIU a milliliter, inappropriately high, and C-peptide level of 3.0 nanograms per milliliters, confirming endogenous hyperinsulinism. Imaging studies, CT scan of the abdomen revealed a 1.5 centimeters hypodense lesion in the pancreas. Endoscopic ultrasound confirmed the presence of a 1.5 centimeters lesion in the tail of the pancreas with characteristics suggestive of an insulinoma. Assessment. A 45-year-old male with recurrent episodes of hypoglycemia, particularly during fasting periods, associated with neuroglycopenic symptoms relieved by glucose intake. Diagnostic workup, including a supervised fast and imaging studies, are consistent with an insulinoma. Management plan. 1. Surgical referral for evaluation and potential resection of the pancreatic lesion. The preferred approach is enucleation or partial pancreatectomy, depending on the tumor's location and relation to the pancreatic duct. 2. Preoperative management includes education on recognizing and managing hypoglycemia, including the use of frequent meals and snacks high in complex carbohydrates. 3. Follow-up postoperative monitoring for resolution of hypoglycemic episodes and surveillance imaging to check for recurrence, given the rare possibility of malignant transformation or metastasis. Outcome. The patient underwent successful laparoscopic enucleation of the insulinoma. His postoperative course was uneventful, with complete resolution of hypoglycemic episodes. Follow-up imaging 6 months postoperatively showed no evidence of residual or recurrent disease. Discussion points. The importance of considering insulinoma in the differential diagnosis of recurrent hypoglycemia, especially when associated with fasting or exertion. The role of a supervised fast and appropriate biochemical testing in diagnosing insulinoma. The critical role of surgical intervention in the management of insulinoma with a high potential for cure in benign cases. The necessity of a multidisciplinary approach involving endocrinologists, gastroenterologists, and surgeons in the management of patients with insulinoma. Galactosemia is a rare genetic metabolic disorder that affects the body's ability to metabolize the sugar galactose properly. Galactose is found in many foods, most notably dairy products, as it is a component of lactose, the sugar in milk. Individuals with galactosemia lack one of the enzymes necessary for the conversion of galactose into glucose, leading to the accumulation of galactose or its metabolites in the blood, which can cause various health issues. Types of galactosemia. 1. Classic galactosemia type 1, caused by a deficiency in the enzyme galactose-1 phosphate uridylyl transferase, GALT. This is the most severe form. 2. Galactosemia type 2, due to a deficiency in galactokinase, GALK, leading to cataracts but generally milder systemic effects than type 1. 3. Galactosemia type 3 results from a deficiency in the enzyme UDP galactose 4' epimerase. Its symptoms can vary widely from mild to severe. Symptoms. In newborns, symptoms typically appear within a few days after consuming milk, which contains lactose, and may include jaundice, yellowing of the skin and eyes, vomiting and diarrhea, poor feeding and failure to thrive, lethargy, Escherichia coli sepsis in neonates, cataracts, particularly in type 2, developmental delays, speech difficulties, liver dysfunction. If untreated, galactosemia can lead to serious complications such as liver disease, intellectual disability, sepsis, and even death. Diagnosis. Newborn screening. Galactosemia is typically diagnosed through newborn screening tests. Enzyme activity assay confirms the diagnosis by measuring the activity of the relevant enzyme, GALT, GALK, or GAL, in red blood cells. Genetic testing can identify mutations in the genes responsible for galactosemia. Treatment. The primary treatment for galactosemia is the complete elimination of galactose from the diet. This involves avoiding all milk, dairy products, and other foods containing galactose, using soy formula or other lactose-free formulas for infants, monitoring for and managing complications such as speech or developmental delays through supportive therapies. Management and prognosis. With early diagnosis and strict adherence to a galactose-free diet, individuals with galactosemia can lead healthier lives, although some long-term complications may persist despite treatment. Regular follow-ups with a healthcare provider, including monitoring of liver function, kidney function, and growth parameters, are essential for managing the condition effectively. High yield points. Galactosemia is a rare genetic disorder affecting galactose metabolism, leading to potentially severe symptoms and complications if untreated. The condition is diagnosed through newborn screening and confirmed with enzyme activity assays and genetic testing. Lifelong dietary restriction of galactose is the cornerstone of management, necessitating careful dietary planning and monitoring. Early intervention and strict dietary adherence can significantly improve outcomes for individuals with galactosemia. Clinical case, galactosemia. Patient information. Age, 10-day-old female, medical history, first child to non-consanguineous parents, uneventful pregnancy, and normal vaginal delivery at term. Presenting complaint. The parents bring the infant to the pediatric emergency department due to jaundice, poor feeding, and lethargy. History of present illness. The infant was initially breastfeeding well, but over the past few days has become increasingly lethargic, showing reduced interest in feeds. The parents also noticed that her skin and eyes appeared yellow. There has been a decrease in wet diapers, and the stools are pale. Physical examination. General, lethargic, poor sucking reflex. Vital signs. Mild tachypnea, normal heart rate, normal temperature. Skin, jaundiced, including the sclera. Abdomen, soft, with mild hepatomegaly. Diagnostic workup. Blood tests reveal conjugated hyperbilirubinemia, elevated liver enzymes, and hypoglycemia. Newborn screening test. Positive for galactosemia, indicating a deficiency in galactose-1-phosphate uridylyl transferase, GALT, activity. Confirmatory enzyme assay shows significantly reduced GALT activity in red blood cells. Genetic testing identifies mutations in the GALT gene, confirming the diagnosis of classic galactosemia. Hash assessment. A 10-day-old female presenting with jaundice, poor feeding, lethargy, and hypoglycemia. Diagnostic tests, including newborn screening and enzyme assays, confirm a diagnosis of classic galactosemia. Management plan. 1. Immediate dietary intervention. Discontinue breastfeeding and initiate a soy-based or other lactose-free formula to eliminate galactose from the diet. 2. Supportive care. Manage hypoglycemia and monitor liver function. Supportive care for jaundice, including phototherapy if necessary. 3. Genetic counseling. Provide the parents with genetic counseling to discuss the nature of the condition, inheritance patterns, and implications for future pregnancies. 4. Long-term monitoring. Regular follow-up appointments for monitoring growth, development, liver and kidney function, and nutritional status. Early intervention services may be needed for developmental support. 5. Vaccination. Ensure vaccination against Escherichia coli sepsis, given the increased risk in infants with galactosemia. Outcome. With the prompt initiation of a galactose-free diet and supportive care, the infant's jaundice and feeding issues improved significantly. Regular follow-ups showed normal growth and development during the first year, with close monitoring and adjustments to dietary needs. Discussion points. The critical importance of newborn screening in the early detection and management of metabolic disorders like galactosemia. The necessity of immediate dietary modification upon diagnosis to prevent potentially life-threatening complications. The role of multidisciplinary management, including pediatrics, nutrition, genetics, and developmental services, in providing comprehensive care for infants with galactosemia. The importance of genetic counseling for the family for future family planning and understanding the genetic nature of galactosemia. Growth hormone deficiency, GHD, is a condition characterized by inadequate production of growth hormone, GH, by the pituitary gland, leading to growth failure and other metabolic effects. GH plays a crucial role in stimulating growth, cell reproduction, and regeneration. GHD can occur in both children and adults, but its manifestations and implications differ significantly between these groups. Causes: congenital, genetic mutations, developmental defects of the pituitary gland, or midline defects of the brain. Acquired tumors of the pituitary or hypothalamus, traumatic brain injury, radiation therapy, infections, or autoimmune diseases. Symptoms in children: stunted growth, slower rate of growth, falling below the normal growth curves for age and sex. Facial features: younger appearance compared to peers with a chubby body build. Delayed puberty, slow or delayed onset of puberty. Hypoglycemia, especially in infants, due to GH's role in regulating blood sugar levels. Symptoms in adults: decreased muscle mass and strength, increased body fat, particularly around the waist, decreased bone density, leading to osteoporosis. Emotional and psychological symptoms, such as depression or lack of well-being. Increased cardiovascular risk factors, Diagnosis: GH stimulation tests. The most definitive tests for GHD, where GH levels are measured in response to a stimulus that normally would increase GH release, like insulin-induced hypoglycemia. IGF-1 and IGF-BP3 levels. Insulin-like growth factor 1, IGF-1, and its binding protein 3, IGF-BP3 levels can be low in GHD, reflecting reduced activity of GH. Imaging: MRI of the brain and pituitary to identify structural abnormalities. Treatment: recombinant human growth hormone, rhGH, therapy, the mainstay treatment for GHD, administered through daily subcutaneous injections to promote growth and metabolic functions. Monitoring and adjustment: regular monitoring of growth rate, IGF-1 levels, and adjusting rhGH dose accordingly. Supportive therapies. For adults, treatment may also aim to improve body composition, bone density, and quality of life. Prognosis. With early diagnosis and appropriate GH replacement therapy, children can achieve normal adult height and improved metabolic functions. Adults can also benefit from therapy with improvements in body composition, bone density, and quality of life. HAVS. High yield points. GHD leads to growth failure in children and altered body composition and quality of life in adults. Diagnosis involves GH stimulation tests and imaging to evaluate pituitary and hypothalamic structures. Treatment with rhGH is effective and requires careful monitoring and dose adjustments based on growth response and IGF-1 levels. Early treatment initiation and adherence are crucial for optimal outcomes. Clinical case: growth hormone deficiency, GHD. Patient information: age, 7-year-old male, medical history, born full term via normal vaginal delivery, no significant neonatal issues, history of recurrent otitis media, no significant family history of endocrine disorders. Presenting complaint: the parents bring their child to the pediatric endocrinologist with concerns about his stature. They report that he seems much shorter than his peers and has not been growing at the same rate as his classmates. History of present illness: the child has always been on the lower percentile for height, but has dropped further down the growth chart over the past 2 years. The parents also note that he appears younger than his age and has less stamina compared to his friends during physical activities. Physical examination: height, 3rd percentile for age and sex; weight, 25th percentile for age and sex, indicating a disproportionate height to weight ratio. General appearance: youthful facial features, mild truncal adiposity, vital signs, within normal limits for age, musculoskeletal, no apparent deformities, limbs proportionate to body. Diagnostic workup: growth chart analysis shows a deceleration in growth velocity over the past 2 years. Bone age assessment: X-ray of the left hand and wrist indicates a bone age of 5 years, delayed relative to chronological age. GH stimulation tests, including insulin tolerance test and clonidine stimulation test, both of which show insufficient GH peak responses. IGF-1 and IGF-BP3 levels, both are found to be below normal range for age. MRI of the brain and pituitary, no structural abnormalities detected. Assessment: a 7-year-old male presenting with short stature, decreased growth velocity, and delayed bone age. Insufficient GH peak on stimulation tests and low IGF-1 levels are consistent with a diagnosis of growth hormone deficiency. NASH management plan: 1. Initiate rhGH therapy. Start recombinant human growth hormone, rhGH therapy with daily subcutaneous injections, with dose adjustments based on growth response and IGF-1 levels. 2. Regular monitoring. Schedule follow-up visits every 3 to 6 months to monitor growth velocity, adjust rhGH dosage, and evaluate for potential side effects. 3. Annual reevaluation. Include assessment of bone age and endocrine function tests to guide ongoing management. 4. Supportive care. Encourage participation in physical activities suitable for his stamina and interests. Provide psychological support and counseling to the child and family regarding GHD and its management. Outcome: after 12 months of rhGH therapy, the child shows significant improvement in growth velocity, moving closer to the 25th percentile for height. His parents report increased energy and improved self-esteem. Discussion points: The importance of early recognition and intervention in GHD to maximize growth potential and improve quality of life. The role of comprehensive diagnostic evaluation, including GH stimulation tests and bone age assessment in confirming GHD. The effectiveness of RHGH therapy in improving growth velocity and overall well-being in children with GHD, underscoring the need for adherence to treatment and regular monitoring.